Hello, everybody. Welcome to this session of the PHRN International Population Data Linkage Network Conference. I'd like to firstly acknowledge that we're meeting on the lands of the traditional owners, and we respect each of their past and future leaders. And this week in Australia, it's the week of commemorating the Indigenous people. So it is actually a special time that we're meeting here. This morning in South Australia, we're going to go through a number of interesting speakers as part of this plenary, looking at how we might progress with sharing data across jurisdictions and countries and what you might call technical and governance silos. So I'd like to say that we've got all the answers to share with you this morning, but I'd be honest and say this is a journey of discovery for each of us, and I hope that you'll enjoy hearing from the speakers and feel comfortable about typing in some of your questions into the Q&A, and the panel at the end will look forward to answering those. So without any further ado, I'm going to throw to the first presenter, Matthias Schneider. So Matthias.
Thanks, Chris. So my name is Matthias Schneider. I am a principal data analyst with SANT Data Link in Adelaide, Australia. And I'm responsible for our custodian controlled data repository, which works on integrating anonymized content data from various sources. And while I'm by no means an expert in the area of federated analytics, I am quite familiar with those challenges of integrating data from multiple sources into one environment. And that is really one of the main aims of federated analytics. Today, I will kick off the symposium by introducing the concept of federated analytics. For those of you who are not too familiar with it, I will first describe the general business challenge of dispersed data in the current landscape of relatively siloed data environments. And then I will give a high-level overview of the approach of federated analytics to solve these issues. So why is there a need for federated analytics on data sources from multiple platforms? Well, users of linked data require access to an increasing number of datasets from quite diverse domains, often held in different secure environments, especially for multi-jurisdictional projects. And under the traditional model, this data needs to be moved from several platforms into one central location where it can then be analyzed. And this can pose multiple problems, because the data movement can be quite limited by governance or even technical issues. With federated analytics, the data stays dispersed in the distributed network of data environments, and the analytics happens close to the data by bringing code to the data instead of the other way around. And this makes the analytics faster, safer, and also more controllable. But we will talk more about these advantages in a little while. Let's first look at the traditional model of accessing data from many sources. So when analysts need to use data from multiple origins, this data often needs to travel to one central location, like I said before. And this is then where the analysts access the data and write their code to query the data. The main downsides of this approach are that some custodians are simply too reluctant to move the data out of their protected environments. Moreover, this model also requires sensitive data to travel, which always comes with a risk of the data being potentially compromised. And finally, there is a cost, both in time and in resources, to prepare, move, and also receive the data at the other end. Under federated analytics, analysts who want to access dispersed data do this via a central virtual database, like you can see in this diagram. And from there, they send scripts to each individual platform where the code is run against the raw data. And then only the aggregated intermediate results travel from each environment back to the central database, where the analysts integrate the received aggregate data. So federated analytics basically enables analysts to gain insight from distributed datasets without requiring them to travel. It makes analytics faster since users can take advantage of the combined processing power of many platforms. It is also safer because sensitive data does not have to travel. And it gives custodians more control since the raw data does not leave their protected platforms. And that already brings us to the end of my presentation. Thanks for your interest. I will hand back to Chris. I also want to mention that we have 2 polls for all attendees to participate in. I'll make them live now. So yeah, it would be great if you could have a look and answer our 2 questions. Thank you.
Thank you, Matthias. I'd like to introduce our next presenter this morning, Wilco. And Wilco comes from one of the peak data science agencies in the Australian government, an organisation called Data 61, part of the CSIRO, the peak science body in Australia. So I'd like to welcome Wilco here this morning. If you'd take over, please, Wilco. Thank you.
Thanks, Chris. So while I'm trying to get my screen up, come on, share. Okay, so as Chris said, I work at Sarah's Data 61. I'm a team leader in the Privacy Enhancing Systems group. And what we're trying to build, amongst other things, is finding solutions for sharing of sensitive data. And I want to talk you through the things we've been working on. So first, if you think about data sharing, so the fundamental problem that stands in the way of data access is trust. And I mean, trust can come from a lot of different angles, and mostly the trust problems are not technical. So you can think of like laws and regulation that helps with trust, or even personal connections. And mostly like the success stories in the past are all based around actual personal trust connections between people. But well, to turn around, so what we want to focus on here is how can technology help with building trust? And so the 3 avenues we want to explore here is how can technology help you maintain control of your data? How can we help to make the system more transparent, and on all these things like build trust? Like if you see what's happening, you might trust the system more. And then the other thing is also like you want to avoid oversharing. So if you think of, for instance, what's a good example? A third-party authentication authorization mechanisms, like when you use your Google account to authorize some app to do something, you get presented this list of things you need to share with the application, and it's like super long, and you can get kind of wary. Why do I need to share all these things if I just want to buy, I don't know, vacuum cleaner bags? And so we're looking into this as well. And if you think about like a little data packet that lives in a database somewhere, on its way to become some meaningful output, it has to pass a lot of steps. And each of those steps, there are different stakeholders, they have different requirements, and all of these can be blockers to data sharing. And so you have to consider each of those things on your journey to produce outcomes. And the other important observation here is that data analysts usually are not interested in data sharing per se. They're interested in insights to drive outcomes, like policies and research results and stuff. And that's the power of federated analytics, like Matthias already alluded to that. So if you don't need to share the data set per se, all you need to do is participate in creating insights. And you can do that on premise. And so we're trying to build this federated data sharing pool model where you're in control of your data that stays on premise. And instead we build these layers of control in front of it to have the access in a constrained way to fulfill the controls. And there are like 3 different planes. So the first one is user access plane, and you have to think about like how much trust do you have in those users, and you might want to present your data in different ways. And so we've got different offerings in that space. You could think of, I don't know, having like secure environments where they're allowed to look at your data, or you've got, you perturb the data in a way so that it's kind of private. And yeah, or you even worse, like you could create synthetic views of your data that has only like some properties of the original data, but don't contain any private information anymore. Also, you need kind of a control plane that manage authorization and auditing, and also allows you to manage risks and stuff. And then underneath some plumbing, you kind of have to combine those data sets in some meaningful way. And so I want to go through the offerings we developed so far, the technologies, and let's start with the first layer with the user-facing side. And so we've got this API that applies confidentialisation algorithms to a query result. So we developed this together with the ABS, so that the algorithm itself is from the ABS, and we built the API around it. And the interesting lesson learned here is like the gold standard for confidentialization would be differential privacy, which is a beautiful framework. However, you've got this problem with, oh, it says my internet connection is unstable. Can you guys hear me? Yeah, no, maybe?
Yes.
Yes. Yeah, good. Okay. Well, that Zoom's weird. Where was that? Okay, differential privacy. Yeah, do you got a problem once you want to use a system in the real world? You run into this problem with the privacy budget that like it runs out, and then suddenly you can't share data anymore. And that's not an option for the ABS. Like they're required to share data. And so they came up with the idea that instead of managing your privacy budget, they manage the perturbations instead. And so that means whenever a query hits some subpopulation, you apply the same perturbation again. And it's just a different trade-off, but it allows them to serve repeated queries without running out of a budget at some point. So let's move on to the control layer. So we've got this access control workflow tool, and that, like, the main idea is like it's built around a shopping cart where you like shop for the data you want to buy, and then at checkout time there's this workflow starting where you have, like, it goes to the custodians, they have to grant access or not and stuff, and there's a nice audit trail behind it. Also in the control layer, we've got re-identification risk. So in the past, we've seen some examples where there were data leaks, although the people did a due diligence. Like, think of the Netflix dataset or MBS, PBS dataset. So they de-identified and did all kinds of tests, but that wasn't enough. And so we thought, well, how can we help with technology? And the best way, I think, is trying to measure risks. And so we came up with this way of evaluating a data set and get quantifiable numbers of the risk. And then also it gives you the chance to measure the success of your interventions. So when you start aggregating or dropping features, it gives you an updated number, and you can see where you go. Well, let's go to the plumbing layer. My favorite one. So you have to, with shared data assets, you have to kind of create a combined view where you link the entities together. But unfortunately, often you don't have unique identifiers for persons. And so you have to rely on some quasi identifiers. And we use personal information for that. And personal information is not a fixed thing. Like that's a living, ever-changing blob of information. Like people move or change names and stuff. And so when you create a linkage system, you have to apply some fuzzy matching. You have to account for changes and also for differences in data quality. And so we've got this fuzzy matching thing. And then on the trust side, we thought, well, can we do that without actually having to share the personal information, because it's very sensitive and people are reluctant to do that. We came up with a way of doing it in a privacy-preserving way, where we create some cryptographic fingerprint of your personal information and then match those instead. It's really cool. So I worked on this project. It's open source. Like most of this part is open source. Come to GitHub, have a play. And now with all those technologies, like we showed all the single ones, and we actually started to combine those. We had a project with the ATO, or Taxation Office, and the Department for Education and Training, and we created this prototype to combine data sets into a thing that's called LLEADS, that stands for Longitudinal Linked Employee-Employer Dataset. And in there, we integrated all these different components to have a federated access to this dataset. Yeah, and so that's it. So if you're interested in any of those technologies and want to learn more how it works, feel free to reach out. Yeah, thanks. Back to Chris.
Thank you, Wilco. I'd like to take the pleasure of introducing briefly Professor Libby Roughead, who from my perspective is one of the preeminent researchers in Australia dealing with pharmaceutical data and surveillance. And so, Libby, I'd like you to take over now, please. Thank you. You're on mute, Libby.
Apologies to you all. I left myself on mute. Thank you very much, Chris, and hello, everyone. I'm very excited to be here. We work in the Quality Use of Medicines and Pharmacy Research Centre, and we, there we go. We participate in two federated data environments. One is the Asian Pharmacoepidemiology Network, and I've got the website there, and the other is the Observational Health Data Sciences and Informatics Collaboration. These networks have been set up with a specific focus on medication safety, and Nicole is going to talk to you later about our participation in the Observational Health Data Sciences one. But we were founding members of ASPEN, the Asian one, and so I wanted to share with you our thoughts and learnings about starting a federated network. To put our work in context, and you know, this kind of stuff's very timely in the idea that we're bringing a COVID vaccine to market. But normally when we bring a medicine to market to treat a chronic disease, we only tested for about a year in about 1,700 people. So it's insufficient to know if we've got rare side effects. We only know 50% of the harms of the medicines when they're first brought to market. We need very large data sets to identify rare side effects, and single countries don't usually have the volume of data to do that. We have other problems, such as often we do medication studies in one ethnic group, and historically it was predominantly in Caucasians. There are pharmacogenetic differences between ethnic groups, and so we need to understand medicine safety about all people in all over the world. And then finally, medicine use is not the same all over the world. So some medicines are available in some countries, and if we don't have safety work there, we don't know about the safety of those medicines. So what happened was this concept, because Asia was a neglected space for medicine safety, that we would set up the Asian Pharmacoepidemiology Network. We'd have an emerging serious safety issue in one country, and we'd tell other countries in the region about it and see if we could set up an intensive monitoring program and do this research. I was at the initial meeting to discuss a concept going forward in 2009. The group wanted to look at the association between antipsychotic use and diabetes. This was a really well-known association. However, none of the research had included people from Asia, and diabetes was much more prevalent in some of the Asian countries. And so the initial plan was to undertake a cohort study using a common protocol approach. I sat in that meeting and thought, oh, this is way too hard. We had been working with linked data for about 5 years then, and we were just on top of kind of the technical expertise to do this. And I was sitting in a room, we were 6 different countries from Asia, Oceania, we were 5 different languages, we had 5 different alphabets, we had different health systems, we had different funding and regulatory agencies. This was the first time we'd tried to do something with medicine use where all the countries had different medicines on the market, and there was limited technical capacity in Asia. So I thought, well, let's do something a bit simpler and let's do something on signal detection. And the reason I chose that is I was pretty confident we could get a result within a year. I have to say that the other professors in the room didn't jump with enthusiasm to my idea because it wasn't proper research, I think they thought at the time. So what happened? We chose this method, and this is some of the important things about starting. We chose a very simple method called sequence symmetry analysis. Why did we do it? We needed one data table from all of these different countries. We only needed 3 variables in the data table. Because we weren't going to collect enough data or much data, we wanted a method that was robust to confounders, and we wanted a method that we could adjust for differences in the market. So it was just a minimum data set like this. This is all we need. So you can see it was very, very simple. But we'd validated the method and we knew it was robust for detecting signals of medicine safety. So what did we do? I sent an invitation to all the people who were at that meeting, and we wanted to first understand if we had common data and the availability of the same medicines, so stumbling blocks all the way along. We got 9 responses, and Asia became a very varied place because Sweden responded and America responded. But what was really nice for us is we were sitting here in Australia with a data set of 300,000 people. Korea came back with 50 million, Sweden came back with 9 million, Taiwan came back with 23 million, and the US came back with more than 150 million. So some of those data sets were electronic health records, some of those data sets were administrative claims data. Everybody, so for the dispensing data, the medicines data that I needed, everybody had the same information that was key, and all of the countries except the USA were using the same international identifier for their medicine coding. We'd also asked about other data. Only the USA had the diagnostic primary care data at that time, but all of the other countries had diagnostic data in their hospital data sets, and everyone was using ICD. So we knew we could do this. So what happened? Oh, sorry, forgot. The initial question we looked at was antipsychotics and acute hypoglycemia. And that was because that was the question that had come from Asia. However, acute hypoglycemia, really rare event. Hypoglycemia, non-acute, common and well-known, but this one really rare. But what was interesting, there were 50 different antipsychotics available across the countries, but only 4 were common that we could use in our question. And some 16 products were only available in 1 country. But we sat here in Adelaide, this is Adelaide down here if you're not sure, wrote our code and distributed it all over the world. So Nicole wrote the code, thanks Nicole. We had a common SAS code with global macro variables. So we didn't ask anybody to change their data set because this was the beginning of our story. We just asked them to fill in the X's, and we had macros for our data analysis. We had a common output file, and so we could end up with usage graphs, new users, how many incident users there were, prevalent users, and then what was our signal, which is called this PSSA analysis table. Just as we predicted, medicine use was really variable across the countries, and I'm just showing you 3 here, Korea, Taiwan, and Sweden, and this is the different major classes of antipsychotics that you're looking at, typical and atypical. But the great thing was our signal detection method worked, and we've got olanzapine and insulin on the right, left-hand side, sorry, and risperidone and insulin on the right. And while most of the results aren't significant, the point estimates sit with what was known. That olanzapine is quite known to cause metabolic syndrome, risperidone rarely, and most of our countries lined up. So we had a result, we had it within a year. It wasn't fantastic science, but what it really did was this. It made us a group and it established relationship. It enabled us to start doing all sorts of things together. So you'll remember we started with the dream of a common protocol approach. We actually started with a common analytic program. What happened is that paper came out, the antipsychotics and acute hypoglycemia. It led to 4 others, and including ones led by regulators in Canada. Health Canada led to this one on proton pump inhibitors, because we'd now developed a method that was simple enough to be even used by non-researchers. They could use it in the government databases. We went on to do more sophisticated methods, self-controlled case series, and the common protocol, it finally got published in 2018. So that journey took 10 years, but the common analytic program we got out quickly. And now people are moving into a common data model, and many of these countries can now participate in the Odyssey network, which Nicole will talk about. So I'm just going to finish there, because I think what for me was exciting is that I think the opportunities both within and across countries are limitless in this kind of techniques for supporting population health. I just think about our own federated country and think about, you know, we have different policies for child protection all across the country. We have federated data sets on birth defects, drugs of addiction, mental health. It would be great to know. So some of this work's really good for understanding policy variation and how policy variation impacts on health. I think we've had a lot of talk at the front about the data sets and building the data sets and de-identifying the data and all those nice things that Data 61 are doing. But I think building relationship is also one of the fundamental things. And I think we wouldn't have got, so the trust in data, but the trust in people. And I think by starting with something simple, doable, feasible, that was kind of what enabled this to happen for us. And I'll stop there. Thank you very much.
Thank you, Libby, for sharing your wisdom and your journey there. And there's probably some sound logic and science to what you're saying about keeping it simple in the process of building something grand. So it's my pleasure now to welcome to the stage Dr. Tim Churches, who's one of the
yes, sure. Right. Thanks, Chris. I think you dropped out there, but I'll proceed anyway, presuming everyone can hear me. So this is a quick talk about Erica, which is a cloud-based platform that we've developed over the last 5 years at UNSW for secure remote access health data analysis. And I'm just going to quickly describe the Erica platform and then talk about its prospects for enabling federated data analysis. So what Erica does is provide not just a single platform, but in fact it's a cloud orchestration meta framework for establishing multiple Erica instances. And an Erica instance provides up to 256 secure remote access analysis project spaces. And typically an instance is run by one institution or organization, and it provides project spaces for projects undertaken by researchers within that institution. And it provides an enclave model, which I think most of you will be already familiar with. Each project space is remotely accessed by researchers, so the data stays in one place. It doesn't go to the researchers' desktops or laptops. And the project spaces themselves are completely self-contained, disconnected from other projects, from the internet and from the users' desktops. And it provides an invigilated gateway for data coming in and for research results going out with a complete audit trail. And Erica in particular is built on Amazon Web Services, one of the popular commercial cloud computing providers. And it's built to leverage the many features and scalability that these cloud providers provide. and it can provide things like different operating systems and virtual workspace configurations for end users, including Linux-based workspace stations. And increasingly importantly, high-performance computing facilities can be provided on demand. So if researchers doing deep learning or machine learning need servers with multiple GPU cards and so on, which can potentially cost a capital costs of $50,000 or $100,000, these things can be provisioned very, very quickly, and the researchers can use them just as they need them. I won't go through this diagram in detail, but it gives a sort of overview. That's showing just one ERICA project space, and the researchers access that remotely. But each ERICA instance can support many, many such project spaces. But the key thing, the important parts of ERICA with respect to federation is that ERICA instances are very much organisation or institution based. So we're not operating a my slide. I've just been sent a message saying my slides are not being shared. I did click share screen. I'll try again. Okay, perhaps this is better. Okay, we'll start. We'll recap.
We do have plenty of time, Tim, so you can take it.
Okay. Sorry about that. It said it was sharing. I won't repeat what I've just said. This is the diagram that no one can see. We'll move on. So the main thing about ERICA is that the instances are organisation or institutionally based. So ERICA is not one facility that provides services to researchers in different universities and so on. It's a facility that allows each university or organisation to set up their own ERICA instance and provide those services to their own researchers. And this is important because that means that the instances are governed and managed by the host institution. All of the policies and protocols apply. You can use site licenses from each institution for software and so on and so forth. So at the moment we have multiple instances currently, one at UNSW Medicine, Australian Institute of Health and Welfare have an instance, New South Wales Government Data Analytics Service have an instance, and next year with ARDC funding, there'll be 3 more instances set up at University of Melbourne, SANT Data Link, and University of Western Australia, and combined with West Australian Department of Health, plus others to be announced. So the other thing about ERICA is that everything is code driven. It's an orchestration framework, and this is important because it provides testable and tested correct behavior. So system administrators don't manually configure anything. Project spaces configuration and operation is entirely point and click, and many of those aspects are configurable by project end users, so the researchers themselves. And the key thing here is that doing it this way is absolutely vital for minimizing human error. The problem with cloud services is that they can be extremely secure, but they can also be extremely insecure if they are configured wrongly. And most of the instances of reported problems with cloud-based data result from misconfiguration through human error of someone clicking on checkboxes wrongly. In ERICA, no one clicks on any checkboxes. It's all done via tested program code, and everything is several layers removed so that even the system administrator can't make mistakes in configuring the service. And on the back of this, we've been able to get accreditation in New South Wales from New South Wales Department of Health, and we're pursuing security accreditation at the Australian government level as well. Because it's an orchestration framework that allows multiple instances to be set up, we're running a consortium business model. So this is not a product that UNSW has developed and sells or licenses to others, but rather other institutions join a consortium, and all members of the consortium have full access to the source code, rights to modify it, but not to distribute it to others. And because everything is set up on a strictly DevOps model, and I won't go into the technical details of that, it makes it very easy for software enhancements for in the overall environment to be deployed, despite the fact that there are many instances in many places. So it's basically automation of software upgrades that most people are familiar with when they upgrade their iPhone and similar. We have those sort of mechanisms to easily roll out upgrades to all of the Erica instances. I won't go through 5 safes, we're aware of that, nor will I go through what Erica does, although I should mention that one of the advantages of the consortium arrangement is that we can, for instance, and we have developed specific Erica training, which can then be shared across institutions. This training's all online, and it comes with assessments and exams and so on and so forth, which goes a long way to creating safe people under the 5 safe framework. But of course, Erica mainly addresses the safe setting part of the 5 safes, and in particular, the threat model is one of that researchers are honest but sloppy, and typically researchers are ignorant of IT security, or certainly haven't had specific training in it. They're very much reliant on their institutional IT security, which is often obscure and hard to find out what's actually being done. And of course, researchers are driven by convenience and pressure to publish. So Erica is designed to protect against innocent acts of omission by researchers and acts of carelessness by researchers, such as having data on memory sticks and then losing them on the train. And also, of course, protects against malicious acts by non-users, that is, external hackers. But it doesn't necessarily address malicious acts of commission by researchers, such as, for instance, filming the screen as they scroll through data. Systems that do address those sorts of malicious acts of commission by researchers have been trialed in the past, and they've, I think, in general found to be unworkable, or at least extremely unpopular with researchers. But everyone acknowledges that researchers are certainly not motivated to do the wrong thing, and through audit trails and so on, most researchers will realise or understand that such malicious acts are career terminating, not just career limiting. I won't go through all the details of how we go about this, but we provide a lot of audit trails and audit checks around this. And finally, we also address safe outputs by providing training and tools for researchers to check for statistical disclosure control issues in the research outputs that they're taking out of the environment. And we have training modules around that as well. So now to get to the point of this talk, what about federation? So Erica, and I guess cloud-based facilities like it, it's not absolutely unique, make it very easy to establish lots of instances, each supporting many project spaces, but absolutely by design, these instances and project spaces are of themselves isolated and self-contained. That's the whole point. However, all of the commercial cloud providers that these sorts of facilities are based on, we use AWS, but the same is true of Microsoft Azure, Google Cloud, and so on, provide mechanisms for securely collecting these enclaves, which can be built on their services. So in the Amazon instance, AWS, they have a product called AWS Private Link, which provides a very secure and again entirely code-driven and thus automatable mechanism, which can be used to link Erica project spaces within and across Erica instances. And I mentioned AIHW, Australian Institute of Health and Welfare, have an Erica instance called SHREI, and they are using AWS Private Link at the moment to selectively share data between project spaces and to provision data into project spaces in their instance. And we'll be doing more work in that sense in the forthcoming year. So essentially that gives us technical mechanisms to very easily set up and tear down wormholes between Erica instances. But the bigger question is federations to share what? So securely and selectively sharing, or more specifically pooling data, is still required, I think, for many types of analysis, particularly if you're doing cutting edge, world-class publishable research. And although there are lots of work being done in distributed statistical and machine learning computation, which is very promising, it's still quite limited in what it can provide. And if you want to use the cutting edge machine learning methods, they're not going to be provided in a distributed fashion. So therefore, bringing data together is still required by many projects. And we think that Erica and platforms like it can provide streamlined mechanisms for both the mechanics, the governance, or at least mechanisms to support the governance and oversight and auditing of such selective project-specific data pooling. But it is, of course, very case-specific. But, and I think this is important, a lot can also be done using shared nothing distributed analysis, which has already been described by Libby, and I think Nicole's going to talk about it in more detail as well, where an analysis script such in R, Python, or SAS, written once and can be run in many places, and only the results of that pooled. But of course, that presumes a high degree of syntactic and semantic interoperability between all the data collections being used in that. And if you've only got 3 columns, that's relatively easy. If you're dealing with complex EMR data, for instance, that's a lot more challenging, but it is doable. And at the moment, there are several projects hosted with the UNSW Medicine Erica instance, which are working on conversion of EMR and other clinical information system data from cancer and ICUs into the OMOP common data model format, which I think Nicole's going to talk about in detail. This is this is an overview. One of the projects that I'm involved with, SAVAR stands for cancer variation, so looking at cancer treatment variation, in fact, and it's taking data from the 2 main cancer clinical information systems used in Australia, Mosaic and ARIA, and converting them into a single OMOP data model with oncology extensions and harmonizing all of the codes and terms and concepts in that. That work's well underway, but I have to say it's not trivial. And we're talking about person years of effort to address this just for these 2 cancer information systems, which I say are widely used around the world, but it's not a trivial undertaking. But I think this is really the next frontier for federated data analysis, is working out methods to do this data harmonization more efficiently than it's been done in the past. And in the SAVAR project, we're very much concentrating on use of machine learning methods to automate these tasks as far as possible. But that's an entire different talk. I'll stop there and stop sharing my screen. And apologies for the glitch at the beginning.
Thank you. Thank you very much, Tim. I'm sure all of us actually enjoyed that talk. It was very insightful and forward-looking. So thank you. It's good to get an understanding of what you've been working on, at least a taste of what you're working on. It's my pleasure now to introduce Nicole Pratt, again, one of the local personalities here in South Australia, or Adelaide. And as part of the conference that we're originally going to run physically here in Adelaide, I'd hope that we had the opportunity for some of you people from overseas to come to our sunny climes here in Adelaide and get to meet and work with us face to face. But we'll look forward to doing that once Libby's sorted out the vaccine safety matters that we need for the future. But I'll now pass to Nicole. Thank you.
Okay. Share my screen. That's all good. Yep. Okay. Well, that's been a great segue into what I'm going to be talking about. So all of the speakers have really set the scene nicely for what I'm going to present here today about the OMOP common data model and how we use the Odyssey network to kind of get this distributed network analysis working. So let me just, right, let's cast our minds back to March 2020, start of COVID, and there were some news reports come out that were suggesting that medicines that people take for hypertension could be deadly in coronavirus if people were to be infected. And that is because some of the hypertension medicine treatments, ACE inhibitors and angiotensin receptor blockers, were sort of a mechanism by which the virus could enter the person's cells and likely lead to more severe illness. So that came out in March, and that led to the American College of Cardiology actually, I'm just getting myself out of the way, sorry, excuse me for a minute, releasing a statement suggesting actually there's no clinical or experimental data that actually demonstrates that these medicines are either beneficial or cause harm. So please don't stop taking your medicines, consult with your doctor, and suggested that additional research needed to be done to actually understand this problem. So of course, research is a go. It was a challenge to work out actually what was the benefit or the risks of these medicines in coronavirus. So off the researchers went, they each had their own data source, performed an analysis and got a result. 3 different databases, 3 different analysts interrogating those databases, 3 different analysis programs, and unsurprisingly, 3 variations of a result. So that led to, in June, different reports coming out of the safety of hypertension medicines in patients with coronavirus. And now the report was suggesting that actually some of the drugs might be protective, and those who weren't even taking their medicines might be at higher risk. So you can see there's quite some different stories going on. So is there a better way? Could we take each of those different data sources? Could we translate them into a common data model or a common structure so that those variables are in a similar, or the data sets are in a similar format? So a common format for storing the data. And then could we translate the data that's contained within those data sets or in those data sources into a common language, a common representation of the data elements that are within them? So now we have a distributed, we could use this as a distributed network of federated secure research data environments. Every data source is still maintained within its own firewall, still has exactly the same security. It could be a Shore instance, it could be an Erica instance. It is in the same secure environment, but it just has a common language and it has a common format. So then that leads us to common analytics. We now have the same structure, we now have the same language, so we can have the same analysis method, the same analysis program to interrogate each of those data sources and produce analysis results. And what Libby talked about earlier about the ASPEN network is actually we can also have a coordinated approach. We have relationships across the data sources. They're not individual silos. They are related together because of a common philosophy and a common, work standard. And that brings me to the Odyssey network. So the Odyssey is a federated data network. It's completely open source. It's completely voluntary. But it does contain data sources of well over 100 different databases. This is an old slide and there's many more databases now. And each of those databases and each of those pins across the world has been translated to an OMOP common data model. And that means we now have a distributed network of over 200 million patient records from all across the world. So the OMOP common data model looks like this. This is the common structure. We have a person table and all the clinical data elements attached to that person. So we have a common data structure. So everything has a place in the common data model. We use a common vocabulary, which means that we have the same language across the different databases that have been translated into the OMOP common data model. And it's kind of like a travel adapter. We have, an iron that works here in Australia, but I just attach a travel adapter and that iron works as an iron in any other country that I want to travel to. So it really means that we can standardise our research output using a common structure and a common analytic file. So as I mentioned, we have the common data structure, and then what we do is we translate the elements in our source database into the common data model format. So we have a destination for each of the variables that we have in our source database. They go to a particular place in the destination database in the OMOP-CDM. The same with translating the data. We work through the idea of a concept. So every data element is mapped to a concept ID through the use of vocabularies. So there are lots of different vocabularies that OMOP uses, standard international vocabularies, so around about 78 of them are from external sources, that have already been created, and some are created internally in OMOP. Here's just a quick example of female, for example. So gender equals F in the source database is the same as gender concept ID 8532. So every female across the world is identified as 8532 rather than female. And the same for medication codes. Your source data in your medication code gets translated to a code in the destination database, and also the same language. So acetaminophen is the same across all countries, whereas in Australia we call it paracetamol. So this is just an example of all the different vocabularies in all the different databases across the world. They all get mapped to a single RX norm vocabulary. For conditions, the vocabulary is the SNOMED codes. So we have data analytics that can now be run against the OMOP common data model, do standard analytics, and also have a network around how to build those evidence generation tools, those standard analytics in an evidence suite. I'll skip through this, but this is just to say there's a front end. Once your data is in the OMOP-CDM, you have the ability to create analytic packages. So in R, you can create a package to do a prediction model, for example. And then what happens is that prediction package gets distributed across the world. It gets run against a database that has been transformed into the OMOP-CDM. The results get generated, and only at that point do the results jump over the firewall, and the summary results are able to be analysed or meta-analysed across the countries that participate. This slide is really just to say that because we have this system, we have a network, we have a common data model, we can upscale data analytics by really producing a single analytic code or even an app that does this and producing the evidence. So just lastly, evidence in action, how these networks actually can generate evidence and questions. We had a Odyssey Symposium, was meant to happen in March, but of course COVID happened in March, so we did a study-a-thon instead. And we answered that question that I started out with: do ACE inhibitors or angiotensin receptor blockers actually increase your susceptibility for COVID or poor outcomes for COVID? And we called this the Icarus study. So the reason why we could do this is because we had databases that were already translated to the OMOP-CDM. And I take Tim's point, it's a really hard process to do up front, but once it happens, you have the ability to do these network studies and respond quickly to questions. So we had 3 different databases, 6 million in the US, 6 million in Spain, and 170 or 12 million veterans in the US. We could quickly write an analytic program because we had standardized tools, and that was open source software. Anybody could use it, and we produced the results. And we did the analysis on 1.1 million antihypertensive users across 3 different databases, produced an estimate within each of the databases, and then did a meta-analysis. And that found actually that there was no increased risk of ACE inhibitors or ARBs in susceptibility to COVID compared to other antihypertensive medicines. This is just to say that paper got published just 2 months later after we did the study-a-thon. So you can see having that upfront investment in a common data model and having that upfront investment in a network and those relationships, we were able to quickly produce an analysis and generate evidence that was important to a question at the time. And that's where I'll end. I think Odyssey is an example of a distributed network using a federated, secure research data environment that actually can enable this analytics across multiple platforms. So that's me. Thank you.
Wow. I didn't know when I was inviting you to present today, Nicole, that you were going to blow our socks off with the work that you've done. I'm sure everybody who's listening is just sitting back going, wow, how do we get some of this? So it's been actually a really useful process this morning, I'm hoping, or today, for wherever you are, to go through some of both the theoretical standpoint and some of the practical work that's happening, and then to finish on some of this work. Now, the great thing about this morning, we're running actually on time, which is surprising. I shouldn't say this morning, today. We're running on time, and I've got the opportunity for people, participants, to fire in any questions. I've got a few here, but and we've also had the poll running, so I'll give participants a chance, if they haven't had a chance to have a go at the couple of questions that we've got up on the poll, and then I'll come back to those and present the results for people. In the meantime, I've got the pleasure, we're going to go to the panel session now, and I've got the pleasure of introducing Kimberly McGrail, who's the professor of at the School of Public Health and Population and the Centre for Health Service and Policy Research at University of British Columbia. And I'm hoping that's the right title or close to it. And Kimberly's going to tell us a little bit about what's been happening in Canada around this sort of ability to share across the provinces, etc. So over to you, Kimberly.
Thanks, Chris. It's great to be here and have this opportunity to speak with you. So I'm just going to take a couple minutes because I really do want to make sure we have time for the Q&A. But what I wanted to talk about briefly is the work that we're doing within Health Data Research Network Canada, which is a newly incorporated network that's been funded by Canadian Institutes of Health Research to build a data platform or data services that will support multi-jurisdictional research. Because like others have said here, we have this issue of a provincial and territory responsibility for data and delivery of healthcare and other services, which means that we have different data in different areas and a need to work in a federated kind of environment. Several of our partners in our pan-Canadian network
I'm hoping Kimberly will come back online and that someone hasn't cut the cable.
One is that we're conducting a legislative review across all of our jurisdictions to really try to get a handle on, it says that my internet's unstable. I probably blipped out for a minute there. Sorry about that. So I'll just start with the 3 pieces of work that we're doing. One is a legislative review to across all of our jurisdictions to see what the possibilities are for data sharing across provincial and territorial boundaries. We know that there are some limits, but it's a little bit unclear exactly what those are. So that sets a context for what we might be able to do. A second is a statistical review, which is really meant to say what kinds of things are going to work in a distributed fashion and what kinds of analyses really cannot be supported in a distributed fashion, no matter how fancy a federated model we might set up. And the third is a technical review, looking at our different secure research environments and really aiming to find sort of a best practice for secure environments, which we think will then help us make the case that it would be feasible and supportable to federate those in cases where it's necessary. So we imagine in the end we'll be in a situation where some analyses are done in parallel, as has been described by some of the other speakers here today. Some we can support with distributed analysis, and some we may need to be able to support pooling at some point in the future. So that's really what I wanted to provide as an update today where we are. Hopefully we'll have lots more to say at the next IPDLN conference about steps forward. Thanks.
Thank you, Kimberly. Coincidentally, we do have a question for you, if I can ask, if you're prepared for that. It was a question of just in relation to how do you navigate the complexities that are common and shared data between the different jurisdictions and provincial laws. So are you able to expand on that a little bit more?
So I guess I'm not sure if the question is about finding common data, given that we have different data generation processes in the different areas.
And trying to sort of get that inter-provincial trends, you know, or differences.
Yeah. It has been tricky. There are some data sets that the Canadian Institute for Health Information holds at a pan-Canadian level. So those are harmonized, if you will, because they have the same standards for data collection. In many other cases, the data are generated differently. So I think it's very similar to Australia, where we have to work on that harmonizing process. We're working through developing algorithms, for example, for common disease definitions and so on. We're working with a network similar to the one that Libby and Nicole described to see if we can produce a common data model that they have developed for drug-based observational research. So there's a few avenues for this, but it really comes down to many of the same things that the other speakers described.
All right, thank you. Tim, I've got a question or two for yourself. So firstly, there's been appreciation from the audience on getting an understanding of how ERICA works. And then building on that was just a question of how you'd apply ERICA in this sort of federated space. And I'm assuming we've touched on it through the wormhole terminology, but if you're happy to expand on that a little bit, if that's possible.
Yep, sure. So ERICA instances and the project spaces that they support are really sort of data and project agnostic. You can put anything you like in them, subject to the governance arrangements for each instance, ethics approvals, and so on and so forth. So you know the technology is very general from that point of view. So what we are envisaging, I mentioned the SAVAR project, which is working with cancer data. We're beginning to work with private sector cancer providers as well as the public sector. So we're currently converting cancer data from Southwestern Sydney Cancer Services, servicing Liverpool and environs, and St George Hospital, also in Sydney, in the public sector. But we're beginning to work with a large private sector provider of radiotherapy services as well. Now, they don't want to pool their data with the public sector or vice versa, but both the public sector and the private sector cancer service providers are very, very interested in benchmarking their results against each other and potentially selectively pooling particular bits of the data to answer particular research questions, but mainly benchmarking. So we envisage that there will be separate ERICA instances for the private sector provider from the public sector providers, and that we'll be able to run these federated queries or analyses across both. And from there, it just scales up. The nice thing about doing it all on the cloud is that the scaling up is relatively trivial when you've got a framework to do it. You don't have to build an entire repository and IT infrastructure each time you need a new node at a new data source or institution. But yes, it's early days for us in terms of the federation.
That's wonderful. We've got about 10 minutes left on the session, and I can see a couple of good questions. So there was one quickly on the panelists' experience using BioGrid as a potential for this sort of federated data sharing. And I'm I haven't looked at Biogrid for probably 8 years, so I'm just throwing to the panel if there's any update insight in relation to the matters we've been discussing. I'll leave that for a couple of seconds. If not, I'll go to the next question. And so it's a more general question about the work that was presented by Nicole and Libby to the other extent. So David Preen's just asked, what are the next steps on how we might enable this to become an accepted and common practice in countries such as Australia, or maybe working across, the national level or international level? So go, Nicole.
Okay, I'll take that one, Liv. So you might see behind me my background. I think it says transformational data collaboration. So there are pockets of researchers in Australia that have come together through ARA that are trying to work together to uplift the translation of common data models in Australia. We happen to be looking at OMOP, Common Data Model. There are others, of course. And what we're trying to do is work together to do that piece of work around the translation of data sets using Australian specific medication codes, Australian specific data sets, EMRs, and so on, and trying to get that sort of a coordinated approach to doing this here in Australia, working with government as well, and working with institutions, hospitals, and so on. So the transformational data collaboration is where you can look up here in Australia if anyone's interested, or look up OMOP as well, and we have an Australian chapter of OMOP here, of Odyssey here as well. So not sure if Lib, you have other things you want to mention?
Yeah, look, I kind of think just to remind everybody to include the end user in the game, and to do things that benefit the, like sometimes we get to be researchers and we think our research is important, but very often in this data space, the data is owned by other people and they want something out of it. And I think one of the things that helped the Asian Pharmaco-Epi network, even though, some of you described that, thought the first ideas were naive, Health Canada could use it. The Korean Drug Information, the Korean FDA could use it. The Australian Government of Health could use it. They were able to run these things through their data set, which meant that they get excited about this stuff. And so, this kind of engagement and opportunity for us all to learn and all to do stuff. I think we often focus on the data, but this other thing about how do we as people come together so that the data serves us all, and how do we cooperate, and that level of trust. So I think that's fundamental to all of this, and it doesn't kind of get enough play.
So Tim here, can I just second that? We're finding, working with the cancer service providers, that really the data custodians and the service providers are most focused on benchmarking of fairly mundane and basic quality assurance metrics, which to us as researchers aren't that interesting, but the putting the data in a common format such as OMOP facilitates that just as well as it does facilitate higher level research questions. And I think that's key, that everyone can win out of these sort of harmonization efforts. But yes, you absolutely have to bring the data providers and the service providers along with you and make it clear that they get benefit out of these efforts, not just the researchers publishing papers in journals.
Thank you, Tim. That's the insight I've had out of this is with SANT Data Link. We look after the Northern Territory, and I know the government there is building big data warehouses and trying to consolidate data across health and human services. And I can see the ability to add the OMOP approach can then actually extend the value and make it able to be integrated. I've got another question for yourself, Nicole. It was in relation to just to validate the model in the work you're doing around linked data sets, and say in New South Wales to build a risk prediction model for a particular disease outcome in the population. How would one use Odyssey to validate the model across other population data sets?
Yeah, that's a great question. And one of the things that you could potentially do is, join the community and ask for participants to validate the prediction model. It would need to be in the format of the Odyssey tool set, so people can run that against their data sources, or you have your own data in the CDM and use the tools that are available in the network. So there are ways that it can be done, and in fact it's done all the time. With the COVID symposium that I was talking to you about, there was a COVID prediction model that was created in the OMOP instance, and that was distributed to, I think it's about 14 or 15 different databases now that have externally validated that built prediction model. So it can certainly be done because all you need is the code to provide to the other participants.
Thank you, Nicole. I might just share people's results from the online questionnaire just as we're wrapping up. So the question on have you used federated data analytics previously came up with 16% of the respondees out of 72 voted yes. So 82% of people in the 80-20 rule close to it. And I'm trying to work out why the numbers don't quite add up. Maths is a wonderful thing. Hadn't used it. And then the other one that was a bit more interesting was, what do you see as the biggest barriers? And I was interested to see the metadata issue around lack of consistency scored 13. The highest was in fact insufficient or inappropriate data governance being the issues that the participants have identified, followed by variability of platform technologies in different data repositories, and then down to the lack of data exchange standards. And then there was another which I can't elaborate on. So I know we've touched on some of these matters through the use of Odyssey and OMAP and other collaborations. And as we're sort of down to the last 2 minutes here, I can draw out the discussion that's come from Libby's focus around relationships and building the trust. And I reflect back to Wilco's comment about the re-identification risk, and the comment from Tim that said something along the lines of the ability to actually manage the risk of re-identification by an actor that wants to deliberately re-identify or release data is extremely difficult. So it settles back to this issue of the trust that the researcher and the research analyst has when working with these large and complex and distributed data sources. And I probably do appreciate Libby's experience here in finding that in having come together with international people of different languages and systems and processes, that you were able to work through something that you were really quite special. I'm just getting a little bit of wind up, and so I'm just going to say a thank you both for the speakers who have given their time for us today and shared some of their journey, knowledge, wisdom and understanding with us, and also for the participants who've taken the time to come and join this symposium this morning or today. And also I should put out a plug for the conference organisers for, at least in these strange times of that we find ourselves in, attempting to bring us physically together in a virtual sense, in a way that we can actually share knowledge, wisdom and hopefully connect. There's no question in having put my hand up to run the conference here in Adelaide a couple of years ago when we were in Banff to try and drive it forward. I'll look forward to a future when we can actually physically meet and enjoy a glass of wine or whatever your beverage of choice is. So I'm probably going to look at closing today, but I just wanted to thank everybody. If there's 30 seconds, if any of the speakers want to just say any final words, but thank you once again.